Welcome to the Hospital Medicine Unplugged podcast.
Today we're undertaking, I think, a really necessary and critical deep dive into the evidence-based management of fungemia in hospitalized patients. This is, well, arguably the most clinically challenging bloodstream infection we face. It demands rapid, high-stakes decisions.
Right, and we're synthesizing the foundational guidelines here, pulling from the IDSA, the Surviving Sepsis campaign, and also looking at the most recent NEJM reviews. And we really have to put a critical lens on that emerging threat, the uniquely difficult Candida auris.
It's a grave topic, definitely. The statistics are frankly alarming. Fungemia, which we define as, the presence of fungi, commonly Candida species, in the bloodstream. It's a leading cause of healthcare-associated bloodstream infections.
And the stakes are just incredibly high.
Incredibly high. When we talk about stakes, we're talking about crude mortality rates that they start around 10%, but frequently climb way beyond 40%. Often, they're exceeding 50% in critically ill patients, in the ICU setting.
That sheer magnitude of mortality really underscores the principle of time sensitivity here, doesn't it?
Absolutely.
Our sources, especially the sepsis campaign, they're relentless in emphasizing that any delay, even just a few hours in getting effective antifungal therapy started or, any inadequacy in the management strategy, it's independently associated with a significant jump in mortality and long-term morbidity.
Exactly. The foundational approach, it really has to be this three-part protocol executed almost simultaneously. You need early, effective empiric antifungal therapy. You need an aggressive search for the source and immediate control of that source. And third, a comprehensive diagnostic workup using both cultures and, importantly, non-culture techniques.
Right.
If we miss any one of those three cornerstones, patient outcomes just decline dramatically. It's that critical.
Okay, so let's begin by framing the risk. The epidemiological landscape of fungemia has, it shifted significantly over the last couple of decades. Historically, Candida albicans was the main player, right?
It was. But the data now clearly indicate a substantial swing, especially in, say, quaternary care centers.
And what's driving that shift?
Well, it seems to be driven by multiple factors. Things like the increasing pressure from widespread azole prophylaxis, and also the changing profile of our immunocompromised patient population. Non-albicans Candida species, they now actually surpass C. albicans in prevalence across many major hospital systems.
And these non-albican species, they're problematic primarily because they bring inherent resistance profiles that really complicate our empiric choices, don't they?
Precisely. That's the core issue. We're now routinely encountering C. glabrata, which has inherent and often inducible resistance to Fluconazole. We see C. parapsilosis, often associated with biofilm formation on intravascular devices. C. tropicalis is common, and critically C. cruzae, which is intrinsically Fluconazole resistant.
And beyond Candida?
Well, in specific highly immunocompromised groups, think hematologic malignancy or lung transplant patients, we also have to maintain vigilance for agents like Aspergillus, Cryptococcus, and even Tellermyces. This whole epidemiological evolution, it directly dictates why we just can't rely on Fluconazole anymore as our go-to empiric agent. It's often not going to work.
Okay, so moving to risk stratification. You mentioned the clinical presentation is notoriously nonspecific, often just persistent fever or sepsis signs that aren't responding to antibacterials. So identifying the patient who needs that high index of suspicion is paramount. What are the key independent risk factors we should be looking for?
The guidelines, they identify a pretty clear interconnected set of factors. And importantly, the presence of multiple factors really compounds the risk exponentially. We can sort of categorize them broadly, maybe as structural, therapeutic, and host-related factors.
Okay, let's start with the structural ones.
Invasive devices are primary culprits here. This includes central venous catheterization, especially those long-term or triple lumen lines, and also urinary catheterization. The longer these devices stay in place, the higher the risk. That's pretty straightforward.
Okay, and therapeutic risk factors.
All right, so total parenteral nutrition, TPN, it provides this rich glucose environment that's just ideal for fungi growth.
Mm-hmm.
And ironically, our own broad-spectrum antibacterial agents play a role. Aggressive use of drugs like piperacillin desobactam or, say, cefepime, it eliminates the competing bacterial flora, which basically allows Candida to flourish.
Interesting. And what about surgical history?
Ah, yes. Recent abdominal or gastrointestinal surgery is a profound risk factor, particularly if there was an anastomotic leak or a perforation or maybe diffuse peritonitis. That disruption of the mucosal barrier and the subsequent translocation of fungi into the bloodstream is quite common in this cohort.
Okay, which brings us to the host factors, which, as you said, often dominate the risk profile.
Immunosuppression is definitely the major independent driver here. This ranges from hematologic malignancy and prolonged neutropenia, we're talking especially counts less than 500, to things like high dose or prolonged corticosteroid use, and of course, patients post-solid organ transplantation.
And critical illness itself.
Yes, critical illness itself. Just being sick enough to need ICU admission, having severe sepsis, or needing invasive mechanical ventilation, that significantly increases the likelihood of fungemia, even if the patient doesn't have other underlying immunosuppression.
So the takeaway is, if a patient checks multiple boxes.
If a patient checks, say, 3 or more of these boxes, like they're in the ICU, they have a central line, and they've had recent broad-spectrum antibiotics, we should probably operate with an immediate presumptive diagnosis, or at least a very high suspicion.
Right. That leads us directly to the clinical presentation. We've said it's nonspecific, but what's the most common presentation that should really trigger an immediate workup in one of these high-risk patients?
As we touched on, I think the most common and often kind of subtle finding is just persistent fever. Fever that simply doesn't break despite, say, 36 to 48 hours of appropriate broad-spectrum and antibacterial coverage. The patient often looks toxic, maybe showing signs of severe sepsis, hypotension, new-onset altered mental status, tachycardia, maybe evidence of multi-organ dysfunction, particularly rising creatinine or liver enzymes.
And we need to remember the unique challenges in the highly immunosuppressed population, right, where inflammation might be blunted.
Exactly. In patients with profound neutropenia or those on high-dose steroids, that typical robust febrile response might be completely absent. Their presentation can be extremely subtle, perhaps just some mild hemodynamic instability or maybe a small drop in their platelet count.
So it can be missed easily?
Very easily. In these cases, the diagnosis of Candida might only be suspected after they fail to respond to our standard antibacterial escalation, sometimes days after the initial insult. The index of suspicion just has to remain astronomically high in this group.
Okay. Given the profound impact of delaying therapy, let's move into the action phase. The mandate for early empiric therapy seems non-negotiable. What do the IDSA and Surviving Sepsis campaigns specifically say about timing?
They're very clear. They state that empiric antifungal therapy must be initiated promptly in any critically ill patient who has risk factors for invasive Candida and, crucially, no other clear, identifiable cause for their septic picture. We cannot, and we should not, delay treatment while waiting for the first blood culture to flag positive.
Because the sensitivity isn't great anyway.
Exactly. The sensitivity of blood cultures is notoriously low for fungemia, maybe only 50 to 70%. Waiting is just too risky.
So we start treatment immediately, and the guidelines are now pretty firm on the preferred first-line empiric agents. It's not really a coin flip anymore between an azole and an echinocandin, is it?
Absolutely not. The consensus preference now for empiric therapy is definitely the echinocandin class. Caspofungin, micafungin, or anidulafungin.
And why the preference?
Well, these agents are preferred for several reasons. They exhibit potent fungicidal activity against the vast majority of relevant Candida species. They have broad coverage, including C. glabrata and C. cruce, while we wait for susceptibility data. And importantly, for critically ill patients, they have highly favorable safety profiles with minimal drug interactions involving the cytochrome P450 system.
Okay. Let's dig into the specifics of echinocandin dosing a bit, and maybe the clinical nuance. Why is the loading dose so critical, and are there any real clinical trade-offs between the 3 main agents?
The loading dose is absolutely essential. It's needed to rapidly achieve therapeutic plasma concentrations. This is critical given the fungicidal nature of these drugs and the fact that the patient is septic. We need therapeutic levels fast.
And the standard doses?
For caspofungin, it's a 70 milligram loading dose, then followed by 50 milligrams daily. For micafungin, it's typically 100 milligrams daily, though sometimes higher doses are considered in specific situations. Anidulafungin uses a 200 milligram loading dose, followed by 100 milligrams daily.
And you mentioned clinical differences. Why might you choose one over the others?
Yeah, the choice often boils down to pharmacokinetics and maybe cost, depending on the institution. Anidulafungin is quite attractive because it's metabolized chemically, not hepatically. That means no dose adjustment is required for patients with impaired liver function, which is, common in sepsis.
That's a good point.
Caspofungin, on the other hand, does require dose reduction from 50 milligrams down to 35 milligrams in patients with moderate hepatic impairment. Micafungin is also generally safe across different types of organ dysfunction. So understanding these sort of minor metabolic differences can be key when you're managing complex patients with multi-organ failure.
Are there specific scenarios where echinocandins are absolutely mandated first line, regardless of local resistance patterns?
Yes, the IDSA specifies 3 non-negotiable mandates for starting with echinocandins. First, if the patient presents with frank hemodynamic instability or septic shock. Second, if the patient has had recent prior exposure to azole agents, which increases the pretest probability of resistance. And third, if there's known colonization or historical documentation of isolation with azole-resistant species like C. glabrata.
Makes sense.
And this preference also reflects a kind of cost-benefit analysis. Yes, echinocandins are expensive, but that cost is justifiable when you're up against a potential 50% mortality risk.
Right. So that brings up the role of fluconazole. Where does this old standby fit into the modern empiric algorithm, if at all?
Well, fluconazole typically an 800 milligram loading dose, then 400 milligrams daily. It's really reserved exclusively for a highly select population now. We're talking about the clinically stable patient, meaning not in shock, not requiring vasopressors, who has a very high likelihood of having an azole-susceptible fungemia, typically C. albicans, and crucially, has had no recent azole exposure.
But that sounds like a very narrow window.
It is. And the caveat is massive. Because of that prevalence shift we discussed toward non-albican species, initiating fluconazole empirically now frequently results in inappropriate initial treatment and a higher risk of treatment failure. We have to be incredibly cautious using it empirically these days.
Okay. And finally, amphotericin B, definitely not first line, but it's still important in our toolkit.
Yes, the lipid formulations of amphotericin B, generally dosed at 3 milligrams per kilogram daily, they're reserved for distinct scenarios. This includes documented intolerance to both echinocandins and azoles, or infection that's proving refractory despite maximal first-line therapy, or perhaps the confirmation of multi-drug resistant Candida that might even be echinocandin resistant, although thankfully that's still rare currently. It remains a potent backup, but often comes with significant nephrotoxicity.
Okay, now let's switch gears slightly to source control. You mentioned it's one of those foundational pillars. Systemic antifungal therapy, no matter how potent, isn't going to work if we leave the source of fungemia just sitting there?
Absolutely. Source control is indispensable. Inadequate source control is a major independent predictor of poor outcome. It's that simple.
So what does that mean practically, starting with indwelling devices?
For indwelling devices, and this is a really critical point, the immediate removal and culture of all central venous catheters, PICCs, any other intravascular devices must occur as soon as fungemia is suspected, provided, of course, it's clinically feasible.
Clinically feasible is the key phrase there, isn't it? What guidance do the sources offer when there's that tension between removing a critical life support device and achieving source control? Like a line needed for pressors.
That tension is absolutely real. If the patient has, say, one central line that is essential for vasopressor delivery and it just can't be immediately replaced due to anatomical constraints or severe coagulopathy, the decision becomes highly complex. The guidelines acknowledge this conflict.
But the preference is still removal.
The strong preference is still removal, ideally within 24 hours. If removal is delayed, that line must be treated only as a temporizing measure, and replacement with a new line at a completely separate site is mandated as soon as it's safe to do so. But for any non-essential line like a dialysis catheter that can be replaced, or a PICC used only for TPN immediate removal, is the standard, no question.
Beyond catheters, what about potential deep-seated foci?
Right. Early aggressive identification and drainage, whether that's surgical or percutaneous, of any deep-seated foci are essential. This is particularly relevant in the post-surgical population. You have to think about intra-abdominal abscesses, anastomotic leaks, or maybe hepatosplenic collections, which can serve as persistent reservoirs for Candida.
So consult surgery.
In those scenarios, yes. A surgical or interventional radiology consultation for definitive source control is just as important as the fungicidal therapy itself. Without drainage, the infection will almost certainly relapse.
Okay. Moving on to the comprehensive diagnostic evaluation. While we're initiating empiric therapy, we still need that definitive diagnosis and speciation to guide eventual de-escalation. Blood cultures remain the cornerstone, but how can we maximize their yield given their limitations?
Yeah, we need to maximize sensitivity because, as we said, it's estimated standard blood cultures might only capture 50 to 70% of true fungemia cases. We use standard aerobic and anaerobic bottles, of course, But when suspicion is very high, utilizing dedicated fungal blood culture media, like the microfluidic bottles, can sometimes increase detection rates and maybe expedite species identification.
And collection technique.
Critically important.
Care.
Obtain multiple sets from separate venipuncture sites. Never just draw from the central line itself, as this can confuse true fungemia with simple catheter colonization. And ideally, yes, obtain these before starting antifungal therapy, but again, and this is crucial, do not delay treatment just to get the draw. Therapy comes first if the patient is unstable.
Right. And in this age of rapid diagnostics, we have these powerful non-culture adjunctive tools. Let's compare beta-D-glucan and galactomannan. What are their roles?
Okay. Beta-D-glucan, or BDG, it's highly useful as a screening tool for invasive fungi, broadly speaking, including Candida and also pneumocystis, because it detects a component of the fungal cell wall. It boasts high sensitivity, which makes it an excellent rule-out test. If it's negative, you feel better.
But specificity is an issue.
Specificity is lower, yes. We have to be aware of potential false positives, things like exposure to certain antibiotics, administration of blood products, or IVG. All of these can contain fungi remnants that might trigger a positive BDG result. So context is key.
And galactomannan, or GM.
GM is much more specific, primarily for identifying invasive aspergillosis. So in our highly immunocompromised patients, like the leukemia cohorts or post-transplant patients, the American Thoracic Society guidelines strongly recommend combining both BDG and GM testing. This combined approach significantly improves the diagnostic accuracy for the entire spectrum of potential invasive fungi infections.
And then we have the rapid molecular diagnostics, which seem like real game changers for getting to targeted therapy faster.
They really are.
Yeah.
The T2 Candida panel is probably the most significant recent development here. It's a rapid PCR-based assay that can detect the 5 most common Candida species directly from whole blood in about 3 to 5 hours.
Wow, that's fast.
It is, and it offers incredibly high specificity and a very high negative predictive value. This means if the T2 is negative, we can potentially de-escalate empiric echinocandin therapy with more confidence, which is huge for stewardship.
But it's not perfect.
No, its sensitivity, while good, can vary, and it must always be interpreted within the full clinical context. A negative T2 does not override a strong clinical picture in positive traditional cultures. It's an adjunct, a powerful one, but not a replacement for clinical judgment.
What about those really frustrating culture-negative cases where the patient remains septic and you still have high suspicion?
Yeah, that's a tough spot. This is where some of the more advanced technologies might come into play. Next-generation sequencing, or NGS, can sometimes be considered for identifying fungi or other unusual pathogens in those specific culture-negative high-suspicion cases. It's not routine, but it's an option.
So it's really a multimodal approach.
Exactly. Culture, antigen testing like BDG-GM, rapid molecular tests like T2 using them together is designed to shave days off the time to a definitive diagnosis.
Yeah.
And given the mortality rates we're talking about, that time is incredibly valuable.
Okay, so once the diagnosis of fungemia is confirmed, the immediate next step has to be that aggressive search for metastatic foci, right? Candida loves to seed deep tissues.
It absolutely does, and failure to identify and treat a deep focus is basically a guarantee of relapse down the line. Imaging becomes essential here.
What kind of imaging?
Well, for our neutropenic patients, pulmonary involvement, especially with mold, is pretty common, so that mandates a chest CT scan. Abdominal imaging, either ultrasound or CT, is critical for ruling out hepatosplenic or other intra-abdominal candida, which occurs frequently, especially in patients post-GI surgery.
And we must touch on the somewhat debated ocular examination. The risk of endophthalmitis isn't trivial.
No, it's not. The risk of ocular involvement, or Candida endophthalmitis, can be up to 16% in some series. The traditional IDSA guideline is quite robust. A dilated fundoscopic examination by ophthalmology should be performed for all Candida patients, ideally within the first week of therapy.
But there's some pushback on routine screening.
There is. We are seeing a trend in some more recent systematic reviews, driven partly by resource constraints and perhaps lower yield in completely asymptomatic patients, suggesting that maybe routine screening could be reserved only for symptomatic patients, those complaining of visual changes or eye pain.
So what's the bottom line for practice now?
Well, until the IDSA formally changes its recommendation, I think the safest course of action, especially given the potential for severe visual loss, is still to screen all fungemia patients. You might tailor this based on institutional protocol and individual patient risk, but the risk of missing endophthalmitis is just too high to ignore completely.
Okay. Moving to targeted therapy. This is where antifungal stewardship really intersects with clinical efficacy. Once we have clearance of the Fungemia and we know the species and its susceptibility, we want to transition from that expensive 5E echinocandin to an oral agent if possible. What are the non-negotiable criteria for making that de-escalation?
Right. De-escalation needs to be a careful, deliberate decision. It should be guided by three key criteria. First, the patient must achieve clinical stability, resolution of fever, off vasopressors, overall symptomatic improvement.
Okay.
Second, and this is critical for mycologic cure, we must have documented clearance of the Candida from the bloodstream. This has to be confirmed by at least 2 separate follow-up blood cultures drawn on different days showing negative
Results, 2 negatives.
Got it. And third, we must have definitive identification of the species and, crucially, confirmed susceptibility documentation via formal susceptibility testing. If any one of these 3 criteria isn't met, the patient really needs to remain on the IV echinocandin.
Assuming all those criteria are met, then oral fluconazole becomes our preferred step-down agent, right? For which species is this typically appropriate?
Yes, fluconazole, usually 400 milligrams daily after an appropriate loading dose if needed, is the preferred step-down for inherently susceptible species, primarily C. albicans, C. parapsilosis, and C. tropicalis. This is really an optimal move for stewardship. It's cheaper, generally well-tolerated, highly effective for these species, and allows for potentially earlier discharge and easier outpatient management.
But the challenge, as always, lies with those less susceptible species, particularly C. glabrata and C. cruce. How do we handle step-down there?
Yeah, that's where it gets tricky. For C. glabrata, which often exhibits dose-dependent susceptibility or outright resistance, we have to be absolutely certain based on the susceptibility report. Transitioning to high-dose fluconazole, say 800 milligrams daily, or maybe voriconazole, is only appropriate if the susceptibility testing explicitly confirms it's susceptible.
And if it's resistant or intermediate?
If the C. glabrata isolate shows elevated MICs or resistance, then continued echinocandin therapy is often required for the full duration. There's no safe oral step-down usually. For C. cruce, which we know is intrinsically fluconazole resistant, we almost always transition to voriconazole, assuming the strain is susceptible to voriconazole, or we just maintain the echinocandin until the treatment course is complete.
Okay. A special consideration here is the neutropenic patient. When can they safely transition off IV therapy? It seems riskier.
It is riskier, and the transition in neutropenic patients is highly guarded. It's generally only recommended if the patient is clinically stable, the isolate is confirmed susceptible, bloodstream clearance is well documented, and most importantly, the neutropenia itself has resolved, meaning the ANC is recovering.
So wait for marrow recovery.
Essentially, yes. If the patient remains profoundly neutropenic, the risk of relapse with oral therapy is just considered too high. We typically wait for marrow recovery before considering a step down in that population.
Now let's tackle the duration of therapy. This seems to be an area of significant clinical controversy and stewardship pressure currently. What is the standard minimum duration, and importantly, when does that clock start?
The standard rule, established firmly by the IDSA guidelines, is a minimum of 14 days of antifungal therapy. And crucially, that clock does not start on the day we initiate treatment. It begins on the day of the last negative blood culture and after the resolution of all attributable signs and symptoms of the fungemia.
So those follow-up cultures are essential not just for clearance, but for timing the duration.
Absolutely. That requirement for daily or maybe every other day follow-up blood cultures until clearance is documented is non-negotiable. It establishes the definitive start point for that 14-day treatment course.
Why is this 14-day dogma so rigid? Why not 10 days, like we often do for bacterial bloodstream infections?
That's a great question. The rigidity really stems from the high risk of metastatic infection with Candida. We established earlier that deep-seated sequelae like endocarditis or osteomyelitis or endophthalmitis occur in a significant percentage of patients, sometimes silently at first.
So the fear is relapse.
Exactly. Stopping therapy too soon dramatically raises the risk of recurrence and the emergence of these life-threatening deep infections. The 14-day minimum is essentially a safety buffer designed to ensure complete eradication, especially from tissues that aren't easily sampled or monitored, like heart valves of the eye.
And for complicated cases, those deep-seated infections we find.
Oh, then prolonged therapy is mandatory. For documented endocarditis, osteomyelitis, or CNS involvement, treatment often extends to 4 to 6 weeks, or sometimes even longer, depending on the specific site, the organism, and often requires a combination of intravenous antifungals and sometimes surgical debridement as well. 14 days is just the minimum for uncomplicated fungemia.
Okay. Let's dedicate some significant time now to the specific and frankly urgent challenge posed by Candida auris. This organism seems unique in its threat profile and has forced major changes in hospital infection control globally.
It really has. The emergence of C. aureus is a genuine public health crisis that directly impacts us in hospital medicine. The major concerns are really threefold. First, its tendency towards inherent multi-drug resistance, especially high rates of azole resistance. Second, its alarmingly high transmissibility between patients. And third, its remarkable ability to persist environmentally on hospital surfaces for extended periods, much longer than other Candida species.
And that persistence leads to outbreaks.
Precisely. That environmental persistence often leads to extremely difficult to control nosocomial outbreaks. It's very hard to eradicate from a unit once it's established.
So, if a patient is confirmed to have C. auris fungemia, what is the mandatory antifungal strategy according to current guidelines?
Because of that near-universal azole resistance, the echinocandins, so caspofungin, micafungin, and anidulafungin, are the absolute first-line therapy for adults and also for children 2 months and older. Rezafungin, which is a newer agent in the echinocandin class with a long half-life, might also be a potential alternative as it becomes more widely available and studied.
Given the documented high rates of resistance across classes, is there ever really a role for oral step-down therapy with an azole for C. aureus?
Very, very rarely. Step down to an oral azole like Fluconazole or voriconazole is only considered if the specific strain is definitively confirmed as susceptible through specialized susceptibility testing. And honestly, that is unusual for C. aureus. For most patients, they will likely require the full course of IV echinocandin therapy.
What if we're using an echinocandin, hitting it hard, but the fungemia persists, say, beyond 5 days?
Persistence is definitely a red flag with C. aureus. It suggests high virulence or potentially emerging echinocandin resistance, which is also a concern. If the fungemia persists for 5 days or more, despite seemingly adequate echinocandin treatment, the recommendation is to immediately transition therapy, or perhaps augment it, with a lipid formulation of amphotericin B.
So escalate quickly.
Escalate quickly. It highlights the seriousness of this particular fungi. We need to pull out our most potent agents without delay if the first line isn't working rapidly.
Now, the infection control aspect of C. aureus is arguably what makes it the most challenging for hospitals. What specific enhanced measures are required beyond standard contact precautions?
Yes, the CDC and IDSA require highly stringent measures because it's so transmissible and persistent. We must implement strict contact precautions. That means single-room isolation whenever possible, or cohorting of positive patients if single rooms are absolutely unavailable.
And PPE.
Universal use of gowns and gloves for all staff and visitors engaging in any patient contact or contact with the patient's environment is mandatory. Hand hygiene compliance is, of course, crucial, but it's really the environmental cleaning protocol that distinguishes C. aureus management.
Right. You mentioned it persists. Why are routine hospital disinfectants, like quaternary ammonium compounds, often ineffective here, and what must be used instead?
That's a key point. Routine disinfectants often fail because C. aureus can form very tough biofilms, and it survives for long periods on dry surfaces. It's much hardier than typical Candida. Therefore, we absolutely must utilize EPA-registered hospital-grade disinfectants that are specifically known to be effective against C. aureus.
And where do we find that list?
These are typically found on the EPA's List P, which designates products effective against C. difficile spores, and now includes those effective against C. aureus. This list often includes chlorine-based products, such as appropriate dilutions of bleach or certain stabilized hydrogen peroxide formulations. Using these specific sporicidal-level disinfectants is absolutely non-negotiable for containing outbreaks and preventing patient-to-patient spread. You can't just use the standard wipes.
Okay. Finally, let's revisit the prognosis and the common complications. We know the crude mortality is high, but what are the specific clinical markers that might predict a particularly poor outcome for our patient with fungemia?
Well, the prognosis is generally poor, as we've said, with crude mortality often hovering around 30 to 40%, sometimes higher.
Yeah.
Clinically, factors that independently increase mortality risk include ICU admission, continued reliance on central lines, implying maybe poor source control, recent abdominal surgery, and definitely failure to achieve early source control.
Any specific lab markers?
Yes. One marker frequently cited in the literature as a poor prognostic indicator, especially in C. aureus fungemia, is thrombocytopenia, a low platelet count. Whether this reflects profound bone marrow suppression from the infection or perhaps a component of disseminated intravascular coagulation, a falling platelet count is generally a worrisome sign.
We mentioned metastatic infection earlier. Could you just detail again the most frequent and severe sequelae that necessitate that aggressive screening we discussed?
Sure, metastatic infection is a frequent and potentially devastating sequelae of fungemia. The most common metastatic foci we absolutely must screen for or have a high index of suspicion for are endophthalmitis, the eye infection, endocarditis, infection of the heart valves, osteomyelitis, bone infection, and deep organ infections, specifically hepatosplenic candida, abscesses in the liver and spleen. Screening with serial imaging where appropriate and maintaining a low threshold for biopsy or aspiration if deep foci are suspected is just paramount.
And specifically regarding C or EOS, is there a unique complication risk associated even after treatment completion?
Yes, unfortunately. Because of its propensity for biofilm formation and its inherent resistance mechanisms, C. archias is specifically associated with a significantly higher risk of microbiologic recurrence and subsequent treatment failure, even after the standard 14-day course appears completed compared to infections caused by other Candida species.
So more vigilance needed post-treatment.
Absolutely.
Yeah.
It necessitates extreme vigilance in follow-up and perhaps a more cautious approach to declaring a cure compared to other types of fungemia.
Given this high risk across the board, let's just reiterate the absolutely essential monitoring requirements for documenting clearance.
Okay. Daily, or at the very least, every other day, follow-up blood cultures until mycologic clearance is definitively documented with 2 consecutive negatives. This is absolutely non-negotiable. Furthermore, serial laboratory tests monitoring organ function, particularly renal function, given potential drug toxicity from agents like amphotericin B or even echinocandins sometimes, and closely monitoring those platelet counts are essential.
And if cultures stay positive,
If we see a patient who seems to be clinically improving, but whose blood cultures stubbornly remain positive after several days of appropriate therapy, we must immediately pivot. We need to aggressively research for an uncontrolled source, an undrained abscess, an infected line we missed, or start seriously considering the possibility of drug-resistant fungi, maybe even needing to switch therapy empirically while awaiting further testing.
Okay, so to summarize our deep dive into the evidence-based management of fungemia, it's clear that despite the complexity, the management principles are actually quite clear, and they're all driven by that urgent need to minimize those truly staggering mortality rates.
That's right. The entire strategy really hinges on adherence to what we can think of as 4 non-negotiable pillars.
Yeah.
First, prompt initiation of an IV echinocandin as first-line therapy for nearly all critically ill patients suspected of having fungemia.
Pillar 1, early echinocandin.
Pillar 2, immediate aggressive source control with a strong prioritization of catheter removal whenever feasible.
Pillar 2, source control.
Pillar 3, an aggressive multimodal search for deep metastatic foci using cultures, maybe molecular tests like T2, and definitely appropriate imaging.
Pillar 3, find deep foci.
And Pillar 4, specifically for resistant fungi like C or hair, the rigorous application of enhanced infection control protocols, including using those specific EP, A-list-P sporicidal disinfectants for environmental cleaning.
Pillar 4, enhanced IC for C or AS. Got it. Now, we spent significant time detailing the standard minimum duration, 14 days of therapy after documented mycologic clearance. However, you noted, and our sources noted, emerging research that's starting to question this 14-day dogma, at least for what might eventually be classified as truly uncomplicated fungemia.
Yes, and that is really the central tension, I think, for antifungal stewardship moving forward. On one hand, we absolutely must avoid the devastating sequelae of deep infection and recurrence, which the 14-day rule helps prevent. On the other hand, potentially shortening therapy duration to maybe 7 or 10 days in truly uncomplicated cases, defined perhaps by very rapid culture clearance, immediate and complete source control, no evidence of metastatic foci on imaging, could significantly improve patient safety by reducing drug exposure, toxicity risk, C. diff risk, and overall healthcare costs.
But the challenge is defining uncomplicated safely.
Exactly. The challenge remains how to define that uncomplicated cohort with absolute certainty and safety. We don't want to shorten therapy only to see higher relapse rates.
So, the final provocative thought for our listeners, building on this, the current standard is clearly 14 days post-clearance. But as new diagnostic tools like T2 Candida become more widespread and perhaps better imaging protocols emerge, how will future guidelines attempt to define uncomplicated fungemia? How can we use these tools, maybe rapid clearance confirmed by T2 negativity plus clean imaging, to potentially identify patients who could safely receive shorter courses, thereby advancing antifungal stewardship without compromising patient outcomes from metastatic sequelae or recurrence? That tension between the pressure for stewardship and the imperative to prevent these severe long-term complications is really going to guide our practice and research in the coming years.